Welcome to the Congressional Integrative Health and Wellness Caucus briefing. Here is your moderator, Dr. David Vogel.
Hello, everyone, and welcome to today's congressional briefing. The pandemic, fallout from COVID-19. Hosted by the Bipartisan Congressional Caucus for Integrative Health and Wellness, together with the Integrative Health Policy Consortium, IHPC. I'm Dr. David Vogel, and as someone whose career has been focused on innovative models of care, I'm honored to be your moderator today. Our presenters are both innovative thinkers and pioneers. COVID-19 has shined a spotlight on key burning issues in our healthcare system, notably the opioid crisis and the urgent need for effective, non-opioid, non-drug pain management treatments. The pandemic has also pulled back the veil on our health system's disparities and racial inequities, worsening already difficult to access pain and addiction treatments. Today's presenters will not just lay out the problems, but also present real solutions. Both presenters are dedicated, forward-looking health professionals that are working within our federal system to create pioneering healthcare initiatives. Today's briefing is one in a series of briefings that IHPC has hosted together with the Congressional Integrative Health and Wellness Caucus, highlighting integrative health's impact on key metrics including cost, health outcomes, and patient satisfaction. IHPC is a nonprofit organization that represents more than 650,000 state licensed and nationally certified healthcare professionals. Its mission is to eliminate barriers to health for all. And among its important work is to champion the Congressional Integrative Health and Wellness Caucus. I want to make a special point here of inviting other members of Congress to join the Integrative Health and Wellness Caucus and play an active role in promoting a whole person approach to health for all. And for the public listening, if what you hear today strikes you as important, please write or call your congressional representatives and ask them to join the caucus. Some quick housekeeping. You can submit written questions by clicking on the Q&A icon at the right-hand bottom of your screen's taskbar. We'll get to as many of your questions as possible. Also, today's presentation will have real-time subtitles. Our program today is being recorded and will be sent out to all participants within a week. It will also be available on the ihpc.org website. So let's get right to it. We start our program with welcoming remarks from our two co-chairs. And for those who aren't familiar with it, the Congressional Integrative Health and Wellness Caucus is a bipartisan forum for legislators to learn about and discuss new research and evidence-based practices from experts in the field of integrative health and wellness. The caucus also provides a platform to create legislative and regulatory opportunities that expand access to integrative health, like the pioneering pain management programs you're going to hear about today. To ensure our co-chairs could be here with us today on a day when there's a lot of activity on the Hill and votes in the House, our co-chairs have pre-recorded their remarks. First, we'll hear from the Honorable Congresswoman Judy Chu from California. Congresswoman Chu was elected to the U.S. House of Representatives in July 2009 and became the first Chinese American woman elected to Congress in history. She represents California's 27th Congressional District. Congresswoman Chu currently serves on the powerful House Ways and Means Committee, which has jurisdiction over legislation pertaining to taxes, revenues, Social Security, and Medicare. She's a member of the Ways and Means Subcommittee on Health, giving her oversight over healthcare reform and crucial safety net programs, worker and family support, and oversight. She also serves on the House Small Business Committee, which has oversight of the Small Business Administration, and she is the co-chair, she's the chair of the Small Business Oversight Subcommittee. Please welcome Congresswoman Chu, and here are her remarks.
Hello, I'm Congressmember Judy Chu from California, and as a co-chair of the Integrative Health and Wellness Caucus, I'm honored to be included in today's important webinar. I'd also like to thank my co-chair, Congressmember Jackie Walorski from Indiana, for her support on helping educate our colleagues and staff about the importance of integrative health in our healthcare system. I'm so sorry that the social distancing measures necessary to contain and defeat the coronavirus have prevented us from joining together in person. But that's why I'm so impressed and grateful that the Integrative Health Policy Consortium has adapted in innovative ways so that you can continue to meet and host virtual events like today's. Unfortunately, the measures we've taken to control the spread of the coronavirus have only exacerbated our fight against another crisis, the opioid epidemic. Social distancing, while essential to prevent the spread of the virus, has left many people isolated, depressed, and vulnerable to addiction. Nationally, suspected overdoses jumped 18% in March, 29% in April, and 42% in May, according to the Washington Post. That's why it's so essential that as we look towards recovery, we ensure that integrative health policies are included. We need to ensure that patients have access to non-opioid, non-surgical options like acupuncture to treat their chronic pain. These therapies are non-addictive and do not carry similar risks of overdose. We've made progress in recent years in fighting for inclusion for integrative health policies, such as our successful push to include a study of barriers to integrative therapies in the Medicare program that was included in the Support Act, the comprehensive opioid package that passed in 2018. It's important that we identify these barriers to access as we work towards expanding integrative therapies for all patients. But here in Congress, our biggest challenge is convincing our fellow members that not only do integrative therapies work, but that they should be available to all patients, no matter how they get their health coverage. That's why I'm so glad to join you here today so you can help share the importance of these therapies with staff from congressional offices. So please enjoy today's webinar and encourage your members to join the Integrative Health and Wellness Caucus. Again, thank you all for being here today.
Thank you so much, Congresswoman Chu, for your continued efforts and all your support. And now we're going to hear from the Honorable Congresswoman Jackie Walorski from Indiana. Congresswoman Walorski was elected to the U.S. House of Representatives in 2012. She represents Indiana's 2nd District. She also serves on the House Ways and Means Committee and previously served on the House Armed Services Committee, the House Veterans Affairs Committee, the House Budget Committee, and the House Agricultural Committee, which she chaired the Nutrition Subcommittee. She served on the conference committee that negotiated bipartisan comprehensive legislation to combat opioid and heroin abuse, and her legislation to prevent overprescription of addictive painkillers to veterans was signed into law. Please welcome Congresswoman Walorski and play her video.
Good afternoon, and thank you so much to everyone who's joining us today. As we all know well, our nation is facing an unprecedented public health and economic crisis. Stay-at-home orders and other restrictions were necessary to slow the spread of COVID-19, but they also resulted in widespread economic disruption. Congress did respond to these challenges with unprecedented relief measures. The CARES Act included direct payments to workers and families. The Paycheck Protection Program helped small business and save jobs. And we provided resources to expand testing and invest in research and development of treatments and cures. Now, states and communities are gradually and safely reopening our economy, but that doesn't mean that the fight against this invisible enemy is over. America is resilient, innovative, and determined, and we will emerge even stronger than we did before. This crisis has also presented serious challenges in delivering non-COVID health care. For instance, many Americans have been able to receive routine health services due to restrictions on elective procedure, medical office closures, and limited hours. To address this, Congress has offered healthcare providers resources and supplies like PPE so they can safely resume seeing their patients safely. With properly managed pain, patients with chronic conditions can lead meaningful lives, achieve greater independence, and maintain steady employment. But not being able to receive in-person care can have some negative consequences for the well-being of patients. We've made great strides in combating the opioid crisis over the last few years, and this is no time to take a step back when lives are at stake. As co-chair of the Bipartisan Integrative Health and Wellness Caucus, I've been working to expand access to non-opioid alternatives to pain management. We're committed to educating patients and providers about these innovative options. I want to thank the Integrative Healthcare Policy Consortium and our panel of integrative health experts for sharing their ideas and insights today. I look forward to learning more. Thank you so much.
Thank you, Congresswoman Walorski. And thank you both for your ongoing leadership and support of the caucus. It is now my great pleasure to introduce Dr. Vanila Singh. She is the immediate past Chief Medical Officer of the U.S. Department of Health and Human Services, where she chaired the landmark Pain Management Best Practices Interagency Task Force. Dr. Singh is a clinical associate professor at Stanford University in the Department of Anesthesiology, Perioperative, and Pain Medicine. If you've ever met Dr. Singh, you know she's passionate about her work and a champion of the groundbreaking achievements that her 29-member HHS task force accomplished last year. The impact of that report's recommendations cannot be underestimated. It should also be noted here that just last week, the U.S. House of Representatives approved the 2021 Labor and HHS Appropriations Bill, with specific language directing HHS to widely disseminate and create a plan to implement the task force recommendations. And now to hear about those recommendations, I'm very pleased to welcome Dr. Vanila Singh.
Thank you so much, Dr. Fogel, for that introduction. I'm truly honored to be here today and to have the opportunity to thank the Honorable Congresswoman Chu and Congresswoman Walorski for their continued commitment to integrative health and wellness, as well as the honor to speak for and with IHPC. If I can get my slides up, I would love to begin this, but I just want to frame that one of the most important things regarding the challenges of pain care has also been, of course, the intersection with the opioid crisis and the real public health issue that was our #1 public health issue just prior to COVID taking over. And in this time, I think it is absolutely amazing that we are focusing time on this very important public health issue that unfortunately seems to be worsening. So this is a great opportunity to speak to all of you, many who are great stakeholders in finding the solutions to help those who are suffering from chronic pain and to help lessen the illicit drug crisis that has really gripped our nation. So I'll go to our next slide, please. Great. So just as a brief review, our current crisis that the Congresswomen laid out so nicely was really the first wave that began back in 1999. It was estimated that about 183,000 people died from the rise in prescription opioids. And I just want to add that some of those folks were not prescribed the opioids, but in fact got them. So there's misuse, there was borrowing, and that led to a death rate that was really tragic in terms of a 4-fold increase in that time that would span 1999 to 2011. Next slide. That first wave unfortunately lent itself to the rise in heroin deaths in the United States. This second wave of heroin deaths also led to another increased 4-fold in death rates. And you could see here the orange line actually represents a linear, almost linear line in which over 70,000 people died, and it reintroduced the concerns of hepatitis C as well as HIV. We'll go to the next slide. And to provide further context, all of us here are so familiar with the illicit fentanyl that has been coming from China and other places, really lending itself to the turquoise line, which shows a rise that was staggering from 2014 that is ongoing to today in terms of overdose US deaths, something that we have not seen in recent years and really surpassed all of the other drugs that we had been talking about. And currently, I just want to bring folks to the next slide, which is really furthering the illicit concerns that we're seeing with our patients, with people around the nation in terms of the psychostimulants, specifically methamphetamine and cocaine with or without opioids. You could see that very solid line and how the current fourth wave is also contributing to near death or overdose death rates. And these are folks who are hurting, whether physically, mentally, and we certainly know that the COVID crisis is not making any of this easy, which is why it is so important that we're focusing on how to better our pain care. And I'll go to the next slide. So just to review, the CDC came out with statistics that showcased that at least 50 million American adults suffer from chronic daily pain or almost daily pain. And some of those estimates are even higher if you consider that it might be every other day pain or migraine pain. However, the real challenging thing to see is that almost 20 million American adults have what we term as high impact chronic pain, where people actually don't have a quality of life, cannot in fact function, cannot work, and that is a staggering almost 10% of our nation's population. So these numbers are really what move us to try and help find solutions. Next slide. The Comprehensive Addiction Recovery Act by Congress in 2016 actually called for the Pain Management Best Practices Interagency Task Force, which was to provide gaps and recommendations to those gaps out there that were found across the nation at state, county, and local levels, and actually was very prescriptive in terms of how to address this. The task force was asked to have federal organizations, HHS convening it, but also with the Department of Defense and the Veterans Affairs Administration, as well as the White House Office of National Drug Control Policy. Non-federal organizations included hospital associations, patient advocacy groups, really important groups there, professional medical organizations, state medical boards, and veteran service organizations. So important to have our vets there. And then specialty expertise in pain, mental health, minority health, substance use disorder, primary care, our pharmacists, our surgeons, our psychologists, toxicologists, and emergency medicine folks, all with great expertise and different perspectives on how to combat the actual issue that was afflicting the nation, both with pain, but also, of course, with the substance use going on around the country. Next slide. So this led to very important information and recommendations, but I want to bring everyone's attention first to what the public was actually commenting to the task force. With almost 10,000 public comments received, an analysis was done with machine learning and AI and really showcased the first and number one issue was treatment access. Many of the patients felt that whatever the treatment modality was, whether it is complementary and integrative health or other measures, their challenge had always been treatment access. And many of them saw very quickly that if they didn't get the treatment, that they paid dearly, whether it was the ability to work or to take care of their kids. Chronic pain, of course, is the number one issue more than acute pain. Many of them suffered from decreased functionality. They were concerned about being conflated with addiction, having issues related to stigma, and unfortunately the rise of suicide amongst those who suffer from chronic pain conditions. Next slide. So the Pain Management Task Force, in the time that it was given before it sunsetted, came up with a solutions-oriented approach that took into account the large number of people who suffer from chronic painful conditions. And mind you, these folks not only may have things that we've all heard of, low back pain or sciatica, but they actually had some complex, less common diseases such as Ehlers-Danlos, sarcoidosis, multiple sclerosis, and everything in between. Specifically also sickle cell disease and a focus on minority health that affects specifically African Americans. All of these things were taken into account with a 5-point multimodal categorical approach and solution. So if you look at the top, medications, restorative therapies, interventional procedures, behavioral health approaches, and of course, complementary and integrative health were the 5 treatment categories that were identified as recommendations to ensure that those different categories were applied to those patients who may need them. But there were also 4 policy categories that were felt to be very important to take into context. Number 1, risk assessment. Doing a risk-benefit analysis through PDMP, urine screens, making sure that the patient had adequate access to their clinician, their doctor, so that they could know from their history and physical what was going on. The stigma that so many of these people are faced with concerning a perceived weakness from both themselves or family members or society as a whole was a big barrier to care, access to care in general, which is something we're talking about today, and of course education for the public, our society, and of course the patients. Next slide. So what we really came out with was a diagram here, a visual, that really helped folks understand how challenging this is. Individualized patient-centered care was very much the focus because, as I mentioned, folks have different causes of their chronic painful condition. It could be migraines, it could be a combination of different things, but they also have their own comorbidities, their own cultural experiences, their own environmental and historical experiences. What we showcase in this diagram is that patient A, B, C, and D may go in to see their clinician, their doctor, and then have a discussion. And what was really important that came through was that the toolbox of all different types of treatment modalities were so important because, as you know, an integrative treatment plan that would be consisting of different treatment options, multimodal options, may result in patient A, B, and C, and D on the right having different needs. So patient A may be required to have NSAIDs, such as ibuprofen, with yoga and maybe nerve blocks. Patient B may actually need a very short course of opioids because of the tragic injury they may have suffered, but also behavioral health and physical therapy. Patient C, acupuncture, perhaps surgery to help with that, and self-management skills. Patient D, gabapentinoids, Tai Chi, and maybe an epidural steroid injection. The point is that patients have different issues, and we need a full toolbox to be able to help them recover so that they have the dignity and quality of life. Next slide. The approach to pain management has to be one that includes a biopsychosocial model of pain management, in which we look at both biological factors, diagnosis, age, what's the injury physically, psychological factors, what is the mood of the patient. Oftentimes the patients have stress and anxiety when they have pain because they know it limits their function and their abilities. Social factors, what kind of social support, spirituality, family support, are they alone? And we're seeing this, of course, with COVID, but this is something that has existed in the pain management arena for years. And taking all of this into account is the only way to really aim to improve the overall pain experience, physical functioning, activities of daily living, and quality of life, all those clinical outcomes that we look forward to. Next slide. So the 5 categories that I mentioned include, number 1, medications. To give folks an idea, there are, of course, opioid, which we want to do with a proper risk-benefit analysis and carefully given all that we've seen in the past years, but also the non-opioid medication options, acetaminophen, NSAIDs, anticonvulsants, antidepressants, many all depending, of course, on the magnitude of the patient's underlying condition. Next slide. The second category were interventional procedures that might be minor, as in trigger point injections, joint injections, peripheral nerve blocks, all the way to more advanced sciences that in the neuromodulation arena, vertebral augmentation, and many different things that are in fact minimally invasive, but still relevant and important to some subpopulations. Next slide. The third category was behavioral health therapies. We know that this is such a vital part of what is integrative health in terms of helping patients cope with the challenges that their medical conditions can provide them. And we're happy to say we were way ahead of the curve in terms of knowing that telehealth was going to be a very important part of getting good behavioral health therapies to folks. Next slide. And then, of course, complementary and integrative health approaches. In this section, we really wanted to ensure that given the magnitude of the task force and the national policy and effect this would have, that we were ensuring to include all the various aspects of complementary and integrative health approaches, including massage and manipulative therapies, yoga, tai chi, spirituality, mindfulness-based stress reduction, and acupuncture. One of the things that I want to state that that Congressman Chu had brought up was the Support Act. The task force was also asked to consult with the Support Act folks at CMS, which we did, and we're happy to say that we believe that the acupuncture for low back pain was certainly one of the outcomes, and we're looking forward to more movement in that arena. But there are many different aspects of the complementary and integrative health approaches that need to be and absolutely have provided such important improved outcomes for some patients. Next slide. The innovative delivery systems, research, and special populations. As I mentioned, we knew that telemedicine and telementoring had a role in this. It wouldn't certainly supplant in-person visits, but we knew that access to care in rural areas, or those areas where people have challenges with transportation and getting to the hospital because of their injuries, their medical conditions, and the chronic pain issues. We also know that research is needed to better understand mechanisms of pain to help actually guide why integrative health solutions would actually and do play a huge role and can actually be preventive and as well as innovative with medical devices and other medicines. And then finally, one of the key things that I really wanted to share with everybody was the special populations that we identified as those with special considerations that often make it very difficult for these folks and may even result in health disparities. Number one was the pediatric population. Very different whole cause, very important to address in life, as many of these folks suffer a lifespan of different issues that can actually result in even worsening adult outcomes. Women who have special considerations, it affects them, how they respond to pain, and of course, some of the stigma that's associated with women in pain. Older adults with their limitations, often with organ-dependent metabolism, their challenges as they get older, and also not to assume that things are just age-related, but in fact, they do impact their functionality, their independence, and their dignity, and to take those things and measures into account. Certainly, integrative health, acupuncture, and other measures are so appropriate in many of these patients. And then American Indians, Alaskan Natives, our active duty soldiers and our veterans have such important issues to consider with the very challenges that they gave during their service or even after. Many of them come with unbelievable chronic pain issues. I must say Walter Reed has brought into the pain arena art therapy and many amazing advanced innovative thinking that we hope will continue to spread for these very well-deserved heroes. And we also focused on chronic relapsing conditions such as sickle cell disease. As I mentioned, this is one that afflicts African Americans mostly. It's a lifespan disease from childhood to adult, and many of these patients face significant stigma with very little in the way of solutions. We need to ensure that we keep an eye on these special populations. Next slide. One of the key things is a risk assessment for risk-benefit analysis. What we wanted to really emphasize in this is that ultimately people are individuals. Having the tools, having access to integrative health solutions as well as other solutions is vital. And when we do consider what could be there, taking stock of what a patient's history, what's their background, what are they in fact encountering, and how do we add things to really bring them into a low risk category so that they have the best clinical outcome possible without taking too much risk in terms of things that could lead to overdose, near death, and certainly other situations. Next slide. One of the things that also that I have already mentioned that I think is really important is the stigma that accompanies patients with chronic painful conditions. Many of them are treated as really second-class citizens, often assumed to be drug seekers, often assumed to be weak. We saw thousands of such comments. People who are truly suffering, have the medical conditions, but because this is often an invisible disease, many of these patients are treated really badly, whether it's by their families, even by themselves, or certainly by our health system in general. And We had many comments. These are just some that actually showcase those very big challenges that are ongoing. And I think there has been a great uptick in this. Myself, having returned from federal service to Stanford and seeing the many patients and how they are suffering with limited options, and of course the stigma that continues with it. Next slide. Education is critical. One of the key things and one of the reasons I'm so honored to be here today is that we felt it was really important to continue to share what is going on with our nation and so many millions of patients, both of course with policymakers, legislators, and folks like yourselves who have impact on regulation, but also to ensure that there was provider education, patient education, and public education. The task force report itself is meant to actually be read by all of these folks. It is simplistic, but thorough and broad, and really addresses all of the issues that we are talking about today. Access to care, certainly the various different treatment modalities, the stigma, and the education. Next slide. Access to care, of course, is improving coverage, which is often limited through prior authorization requirements, condition requirements, visit limits, and referral requirements. We certainly need to expand on this. We need to expand on the conditions that these things can be improved on. Non-pharmacological treatments for pain are often limited: physical therapy, occupational therapy, limited coverage for acupuncture for those who even get the coverage, not enough to actually have what is the optimal need in terms of reaching a better clinical outcome, behavioral health interventions as well, and overall even a multidisciplinary approach where we know that having a medical evaluation along with the psychologist, the physical therapist, the acupuncturist, and others who may be involved to really get that patient turned around, it's important, and people will forget that it is actually economically better too, because it keeps these patients from running to the emergency room when they're having such challenges or inpatient admissions. We know that being proactive with a multidisciplinary approach is the best way to go for many of these patients. There is also a shortage of pain specialists in general. We think that even early referrals or early consultation, one time only, will also help guide a blueprint and name a template so that all our colleagues in their own expertise can get with that situation and help that. More time and resources for assessment and multimodal treatment plans, aligning the payer guidelines with current clinical guidelines, and including non-opioid pharmacologic therapy, but also non-pharmacologic therapy. And finally, having a complex management of pain code. Next slide. Telemedicine, as I already mentioned, it has moved at warp speed. My hope is that we will remain able to do this for pain patients in general. The limited medical transportation ability, the often physical limitations have really allowed for a way to frequently see our patients and ensure that they're doing okay with the treatments that they may have. Of course, this does not replace in-person visits, but for many folks, it has definitely allowed for improved access. I just want to make sure that folks understand just how important it has been in this community. Next slide. And we certainly did some recommendations for the CDC, better quality data for long-term opioids, identifying a subpopulation that may benefit from long-term opioids, and just continued importance in not force tapering people and using our non-pharmacologic, non-opioid options as well as an important part to emphasize and update. Next slide. And this is again just FDA announcement last year about concerns about forced tapering patients, but also more importantly, abandoning patients altogether due to misunderstandings of what pain is. And really, when we are looking at trying to limit opioids, we also have to ensure that we have solutions for those patients and not simply just decrease our opioid prescribing. We need to allow for other treatment options. Next slide. And I wanted to highlight the 150 plus organizations that supported, lauded, and praised the task force. Many of these, including the Human Rights Watch, were very important folks from various different perspectives, including the hospice and palliative medicine folks, the American Society of Acupuncture, the American Psychological Association, our orthopedic colleagues, neurosurgical colleagues, rheumatologists, the American College of Physicians, the American Porphyria Foundation, certainly the sickle cell folks, multiple sclerosis folks, the AMA, was hugely supportive of this. The ANA, the American Dental Association, and on and on. It was an unusual time that all organizations that often have different perspectives and even different asks came forward to support the task force findings. And I'm only saying this that all of you feel a confidence. Next slide. Our main goal is to strike a balance and address both the public health crises of the opioid crisis at this time of COVID, not to forget that many patients are still suffering and in many ways have had it worse with social isolation and the mental health issues that exacerbate their already challenges that are there, and to really optimize measurable functional outcomes, quality of life, and productivity. Next slide. I also wanted to share that many of your colleagues on the Hill, this is a specific letter from Senator Cassidy, but we had many of your colleagues on both sides of the aisle support the task force. Next slide. And finally, I want to thank everybody here for making the time today for such an important endeavor and conversation about integrative health and wellness solutions for the chronic patient pain population. Thank you again.
Thank you so much, Dr. Singh, for your presentation and for the amazing work. It is no small feat to shepherd a task force of this size and come out with such important recommendations with so many stakeholders. So now let me move on, and I have the pleasure of introducing my IHPC colleague, Dr. Sharad Kohli. Dr. Kohli is a family physician working in the Adult and Adolescent Medicine Department at People's Community Clinic in Austin, Texas. People's Community Clinic is a federally qualified health center, also known as an FQHC. It's where Dr. Kohli has spearheaded a pioneering interprofessional pain management program that puts into practice many of the recommendations of the HHS task force. He's a founding member of the national nonprofit organization Integrative Medicine for the Underserved, and having worked in FQHCs for over 17 years, he has dedicated his career to advancing social justice, health equity, and working with underserved communities. Welcome, Dr. Kohli.
Thank you, Dr. Fogel, and thank you to the caucus, Congresswoman Chu and Walorski, and IHPC for inviting me to present. Today, I'm going to be talking about one federally qualified health center that has built a program to address pain that is aligned with the best practices that Dr. Singh just presented. I want to begin with a brief overview of federally qualified health centers. FQHCs are individual nonprofit entities that receive Section 330 grant funding from the Health Resources and Services Administration to provide primary care, behavioral health, dental, and other services in medically underserved regions throughout the country. FQHCs must accept patients with Medicaid and Medicare, private insurance, as well as those who are uninsured via a sliding fee scale. FQHCs came out of the civil rights era and LBJ's war on poverty, so they have a storied history of providing healthcare and other resources to historically marginalized and underserved populations. They're trusted members of their local communities, and there are over 1,300 health centers with over 12,000 sites nationwide, serving around 30 million people, thus making FQHCs the largest healthcare network in the country. FQHCs have added importance right now as millions of Americans are losing their employer-sponsored health insurance due to COVID-19. And as we'll discuss, FQHCs are the front lines with regards to chronic pain and opioid misuse. Next slide, please. Now, People's Community Clinic didn't start as an FQHC, but became one in 2012. The clinic was originally a free clinic started 50 years ago by volunteer doctors and nurses in a church basement to take care of students and others who didn't have access to health care. It's expanded to care for an increasing number of working Central Texas families. It's a patient-centered medical home as well as a community-centered health home, which means we recognize that most of health happens outside of the four walls of any medical facility. So we work in both the clinic and the community to improve health outcomes. Now you can see our new building on the right that we moved into in 2016. Last year, we served over 18,000 unique patients, 85% of which identified as Latino, and 63% of our patients prefer another language, mainly Spanish. 41% of our patients are on Medicaid or CHIP, while almost half are uninsured. Next slide, please. Our impetus for this program lies in the structural issues that lead to health disparities, which can be an entire talk on its own. I'm going to try to summarize it through this map of Austin on the right, which shows life expectancy by zip code. Most of the west side of Austin has a higher life expectancy, indicated by dark greens, while on the east side, where many of our patients come from, where our clinic's located, it's much lower, which are the lighter greens and pinks. Now, this stems from a series of ordinances culminating in the 1928 Master Plan of Austin, along with subsequent federal regulations, which deliberately displaced communities of color. These decades of policies rooted in racism limited economic opportunities, education, access to healthcare, and often created a lot of trauma for individuals and communities. And this is what we mean when we talk about social determinants of health, that the conditions in which people live and work play a significant role in their overall health. The adage is that your zip code matters more than your genetic code. What we know about trauma, especially through data around adverse childhood experiences, is that it leads to higher rates of chronic diseases such as high blood pressure, diabetes, or cancer, as well as depression, anxiety, substance use disorder, and chronic pain. Studies show that emotional pain and physical pain activate the same parts of the brain, and there is a lot of overlap of the neural pathways. So people who have experienced trauma, which are a large number of our patients, may feel pain on their own, or it can exacerbate physical pain that they may have. Additionally, many have financial, housing, or food needs that can increase their stress, anxiety, and ultimately pain. One of the other major barriers here in Texas is that we did not expand Medicaid. The large majority of our patients with pain don't have access to imaging, specialists like an orthopedist or rheumatologist, or even physical therapy. They definitely don't have access to the growing number of evidence-based non-drug approaches. Without many options to help patients with their pain, opioids often end up being prescribed even without evidence of great efficacy. Now, we're lucky in that in our clinic, we don't have a lot of patients who've been prescribed opioids for pain. But we decided to build a program that effectively addressed trauma and pain as a way to improve patients' functioning and quality of life, but also to prevent people from ending up on opioids. In a lot of ways, this is a prevention program. And really, we had no alternative but to build it in-house, as is often the case in FQHCs. Next slide, please. Now, in FQHCs, we have various funding sources, including money from the 330 grant, payments for medical and behavioral health visits from Medicaid and Medicare. In Travis County, payments from our health district to cover eligible uninsured patient visits, and philanthropic funding. This creates our general operating budget, which pays for much of our ancillary programs. One big thing that helped were 2 HRSA grants, which you can see, the AIMS grant, the IBHS grant, that were intended to address mental health and fight the opioid epidemic. These ongoing funds have allowed us to hire a care coordinator who is essential to the functioning of the program and add other elements. These grants are generous, but still fairly limited, and really only provide about a day a week of non-drug treatments like acupuncture and yoga therapy. But it's a start on taking an opioid prevention strategy. Next slide, please. When I joined the clinic in 2018, PCC already had a lot of resources, including a robust trauma-responsive integrated behavioral health department, nutrition and cooking classes, a medical legal partnership, and a partnership with our local Chinese medicine school, AOMA, which had been running student acupuncture clinics. Really, we just needed to integrate the services better and add a few additional pieces. Now, I had experience building something similar at an FQHC in California years back, and had been involved with the nonprofit Integrated Medicine for the Underserved, which for a decade has served as a place to share best practices around pain care in FQHCs and other safety net settings. In 2016, on the left, you can see this white paper was released by the California Healthcare Foundation, which reviewed how community health centers were attempting to effectively address pain and provide alternatives to opioids. What the white paper found is that a majority of clinics addressing pain had these features in common: group medical visits, which emphasize community building and self-management, team-based care, including integrated behavioral health, some non-drug approaches to pain, which were generally not reimbursable, but health centers were incorporating this in innovative ways, and buprenorphine for both dependence and chronic pain treatment. Now, overall, these findings served as a template for our program. Next slide, please. Then in May of 2019, this incredible report from Dr. Singh's team was released, and it validated what we were building and provided us with a larger blueprint as we move forward. The report recognized the need to take a patient-centered biopsychosocial approach. Since so many of our patients are affected by upstream psychosocial and structural factors, this is generally how FQHCs already operate. Next slide, please. This slide on the left distinguishes the difference between addressing unmet social needs and social determinants, which I think is a key point. At the bottom, you see downstream interventions, which is the typical medical care that's provided in a clinic. When we start asking patients about food insecurity, housing, or transportation, we're actually looking midstream at individual social needs, which is incredibly important, and we should continue to expand programs that address these. But if we go further upstream and look to address the conditions that created the food insecurity, lack of housing, et cetera, those are the social determinants. And improving these generally requires policy changes at a local, state, or national level. At our clinic, we address all three levels. In addition to the clinical care we provide, we developed our own social needs screening tool, which is here on the right, called the People's Tool. This is open source, anyone can actually use it. And it ties into various interventions that we offer in the clinic or outside through partner organizations. We use the information we gain to improve clinical care, but also moving into that upstream portion of the graphic to help inform our advocacy work to improve the conditions of our patients and their communities. This is an essential part of what FQHCs do. If we can't create change upstream, we're just spinning in circles downriver. Next slide, please. One specific intervention I wanted to mention, because it's pretty unique and plays a large role in improving our patients' lives, is our medical legal partnership. This program offers on-site legal services addressing health-harming legal needs, such as unlawful discrimination, tenants' rights, benefit denials, and more. In terms of our patients with pain, if someone is being threatened with eviction, that'll increase their stress and typically their pain. Taking that stressor off their plate is usually really helpful. Furthermore, many of our patients aren't able to work and may be eligible for disability, so our lawyers can help with that process. Getting disability usually means getting a small monthly payment, which can help with financial stress, but more importantly, they're able to get access to Medicare and Medicaid, which then allows them to get the imaging specialists, physical therapists, et cetera, that may benefit their pain. We currently have 4 lawyers on staff, and they function as members of our healthcare team. This program was created and is directed by Keegan Warren Clem. Keegan was recently honored as a National Academy of Medicine 2020 Emerging Leader in Health and Medicine Scholar, only the second time a lawyer has ever received that award. You can learn more about the program through the links, and feel free to email her if you have any questions. I will say that now that I've experienced it, I can't imagine working without lawyers as part of our team. Next slide, please. Now, as Dr. Singh mentioned, it's important to work in an individual, multimodal, multidisciplinary fashion. Her team recognized 5 categories of treatment approaches, and at PCC, we have something from each which patients can choose. What this does is allow the patient to work with the healthcare team to come up with an individualized program based on their preferences using this expanded toolbox. Next slide, please. And this is how the program looks in practice. A patient comes in to see their primary care provider. The PCP can prescribe medications or potentially do an interventional procedure like a joint injection if indicated. But they can also discuss the IPMP, and if a patient would like a referral, the PCP makes one, which then goes to our care coordinator at Aseli. She will then contact the patient and let them know about all the different services within the program. The patient can then be referred to the different elements of the program based on their preferences. So that could be behavioral health, where most of our patients start, or our medical legal team, if there's a legal need that's impacting their pain. It could be our substance use counselor if needed, or nutrition, or an exercise class, or a cooking class, or exercise. Or it could be acupuncture, which includes full body acupuncture or ear acupuncture, following what is called the NADA protocol, which has been shown to be effective for trauma, stress, anxiety, and substance use disorder. Or even yoga therapy, which is more than just yoga. It's a one-on-one application of specific yogic tools, including exercises, breath work, meditation, and more, done in a trauma-responsive manner. Now, we were planning on adding massage therapy as it was budgeted in our grant, but COVID has put those plans on hold for now. The other place where patients can get referred to is our chronic pain groups, which is one of the cornerstones of our program. Next slide, please. So for those not familiar, group medical visits are an innovative value-based model where patients receive their medical care in a group. A provider has a face-to-face visit, so it's billable, but there's typically more time for education, information about self-management, peer-to-peer learning, and connection. Group visits are increasingly being used in underserved settings where so many patients are lonely and isolated. When patients are able to come together and realize that there are others who are going through something similar, they often feel less alone and more supported. Patients end up willing to try things that they might not otherwise, they make friends in the group, and they hold each other accountable. As one of my colleagues recently stated, often in our current model of care, we attempt to extract the individual in a way that fails to address the healing nature of community. For our groups, we adapted a curriculum developed by Paula Gardner, a physician in Massachusetts who had received a PCORI grant to create a program specifically in underserved settings. The groups are co-facilitated by our social worker, Kelly, our nutritionist, Diana, and myself. And each session generally includes a nutrition and cooking component, mind-body activity, usually some sort of movement, and most importantly, connection between group members. Now, one last point I'll make about groups is that it's a more casual interaction, which breaks down the hierarchy that often exists in medicine and builds trust. The health team learns more about the patient's concerns, as well as the inherent knowledge patients have around their own health. And this really fosters that patient-health team partnership that's central to shared decision-making. Next slide, please. One other key element of the program are weekly case conferences to discuss complex patients. Now, all the different folks I've mentioned in the IPMP come to these. Oftentimes, some of the first things we do are to stabilize crises and address social needs. So our lawyer and social workers are key to the discussion. One really important point about these case conferences is that, like the group visits that flatten hierarchies between patient and practitioners, these meetings do the same within our healthcare team. Everyone has their own expertise that they bring to the table, and we learn from each other. When more people are comfortable sharing their opinions, you're less likely to miss something, and overall this improves patient care. It also improves provider satisfaction and mitigates burnout. No one person has to do it all, since we all work together to figure out what exactly our patients need. A few of our team members say that these conferences are their highlight of the week. Next slide, please. This program is still very young, so we're in the process of collecting data. It's hard to evaluate pain because it's so complex. We're looking at pain and functioning, behavioral health and physical health measures, opioid usage, and ER utilization. But really, the ultimate goal is to improve quality of life. And we're piloting right now a tool called the Flourishing Measures from the Human Flourishing Program at Harvard. As many of my colleagues state, we're moving from what's the matter with you to what matters to you. Honestly, patients don't necessarily care about their scores on any of these metrics. They care whether they can get back to doing the things that they love. So that's what we're trying to accomplish. Next slide. So COVID-19 has been pretty brutal here in Texas, especially recently, and it's disproportionately affecting our patients. Many are deemed essential workers who are more exposed to the virus. Many have underlying health conditions that put them at higher risk for complications from the disease, and many were already struggling financially before this all hit. Given these factors and the fact that patients may be less mobile and more isolated during this pandemic, we anticipate that patients living with chronic pain will experience more trauma, stress, depression, anxiety, substance use, and ultimately more pain. Unfortunately, the virus has changed so much about how our clinic can operate. Normally on Wednesday afternoons, I'd be in our chronic pain groups. Instead, as you can see in the photo, I'm here standing outside in full PPE in 100-degree heat, swabbing folks in our drive-through clinic. We've had to cancel so many of our in-person offerings when patients may need them the most. But despite this, there's a lot we can do, and we're starting to shift how we provide care. We've begun offering virtual behavioral health, legal care, one-on-one yoga therapy, and substance use counseling. And we plan on bringing back virtual groups, nutrition, and more. We're looking at whether we can offer videos on demand for mindfulness, acupressure, or qigong. We're also working on protocols to safely restart acupuncture. Next slide, please. Now, in terms of challenges, we do have long waits for many of our services, including acupuncture. This is mainly because these services may be limited to a day a week, since they're grant funded and generally not reimbursable in FQHCs, which is one of the biggest barriers to creating a sustainable program. And with COVID, as we start moving to virtual visits, we're recognizing that some of our patients have limited internet access or don't have a lot of experience with technology. We're also losing the in-person connection, especially from groups, which contribute so much to healing. We'll see with time what works and what doesn't, and have to adjust as FQHCs always have. Next slide, please. So I want to close with a couple testimonials from patients. The first is a 6-minute video that you can watch on your own. You'll get the slides and the link will be on there. Next slide, please. But the second is from a patient that we're calling Gloria and is translated from Spanish. I don't have time to read the whole testimonial, but some things to know. Now, Gloria had an aversion to meds initially, so was looking for alternatives. She thought physical therapy was helpful. She joined our groups and enjoyed being with other people. Therapy was really important to her to help with her self-esteem. She changed her diet, which she felt really helped, and began drinking certain herbal teas, which culturally was something she was comfortable doing and which was reinforced in the group. She also got more family support. And according to her, there really wasn't one thing that worked. It was a process and required patience. And one line that stuck with me, and this is what she said was, but in the most difficult moments, none of these things took away my pain. What they did was help me support my body so that it could stay strong, so that I could continue to face or bear my pain. We have to remember that people with chronic pain will likely still hurt. The goal has never been to completely eliminate pain. The question is whether they can overcome it and learn the tools to be more resilient, to still be able to live the life that they want, to do the things that they enjoy. That's the ultimate goal of this program, and I believe the recommendations from Dr. Singh's team as well. Next slide. Thank you so much for this opportunity to present.
Thank you, Dr. Coley. You're really an inspiration to me and many others. Initiating something like this in an FQHC is really an accomplishment. Okay, let's try to get, we're running a little bit over, but let's try to get to a question or two. I'll try and condense them. For Dr. Singh, you've touched on this a bit already in your presentation, but a lot of the questions from the audience are about steps to take to remove the barriers that you spoke about in your presentation. Can you comment on this and what the most effective path forward is?
Well, so thank you so much, Dr. Fogel, for all that, and it was great to hear Dr. Coley as well. I will say that it's important, one, to continue to do such webinars and to get all the different folks out there, the different organizations, to really share some of the common themes that we've heard about today to Congress so that they can be appropriations for this. It's really an investment in our nation to get folks out to better clinical outcomes in terms of functionality, quality of life, and even the idea that as we do better innovations and research and development, I think it is fair to say that we can hopefully get into preventive mode and to really help those who are suffering immensely with the various different treatment modalities. We have oftentimes the solutions, we just need access to them. And so I think better understanding the empathy and compassion that's always necessary in medicine, along with the science, will give the confidence to our lawmakers to consider these options so that folks out there can really get back to work, a productive life, and it affects so many people that I think that their constituents would definitely appreciate it.
Great, thank you. Let's see, Dr. Coley. How many other FQHCs in the country have pain programs like yours, and what's needed to increase that number?
Thank you, Dr. Fogel. Yeah, you know, the bottom line is I actually don't know, and I think I know that there are many right now because we know through like my work with IM for Us, you know, we created that conference to really share best practices of what's happening in underserved communities and around integrative care. But throughout the 10 years that we've been having conferences, we've had multiple FQHCs promoting these pain programs that they're doing. So we know that there are some in rural and urban areas in like California, in Massachusetts, Illinois, Ohio, Arizona, et cetera. But as far as I know, I haven't seen a large survey to see what FQHCs are doing for pain, what the challenges are, what they need. The National Association of Community Health Centers, I know, has also had a collaborative with certain FQHCs that are working on some of these issues. And so it might be great to work with them and Bureau of Primary Healthcare, who oversees the FQHC program, to really, you know, conduct a survey to really see what the needs are and what people are already doing. I think one of the other challenges right now is that you know, many of these non-drug approaches aren't reimbursed in FQHCs, and that's, you know, very variable based on the state that you're in. In Texas, you know, we don't have coverage for acupuncture or some of these other services, and so we've had to be really innovative of how we've done this. So I think, you know, it's going to, you know, these grants are great, but they're very limited in what we can do with them. And I think if we can figure out ways to make these services reimbursable in FQHCs, I think it can make this more sustainable.
Great, thank you. Unfortunately, I see we're coming up on the hour and we don't have time for more questions. So we've seen today how COVID-19 has stressed our health system in ways none of us could have imagined. It's really underscored long-standing disparities and inequities in healthcare. This pandemic has distracted us from the national pain management crisis that was already raging. As everyone has learned today, there is a path forward and there is still urgent work to do. Many of the non-pharmacologic pain management practices highlighted today are not covered by insurance, making them inaccessible, while pharmacologic approaches, including opioids, are. What appears critical is for HHS to develop the implementation plan for the task force recommendations, and judging from our turnout of our listening audience today, the integrative health community needs to be a part of this planning process. We also mustn't lose sight that FQHCs are the bedrock of care for over 30 million people in the country and are our main healthcare safety net. We need to make it possible for all FQHCs across the country to implement non-pharmacologic pain treatment programs as modeled by People's Community Clinic. With this in mind, I want again to invite all members of Congress to join the Caucus for Integrative Health and Wellness and to learn more about initiatives like the ones presented today. I want to thank our caucus co-chairs, Congresswomen Jackie Walorski and Judy Chu, and Congressman Tim Ryan for the leadership and for championing the inclusion of provisions into both the Labor HHS Appropriations Bill and the Veterans Affairs Appropriation Bill. Finally, I want to thank all of you who have attended today, which includes nearly 800 registrants from across the country. I'm Dr. David Vogel. Everyone stay safe, stay healthy, and stay tuned for more briefings in our ongoing series.